Thank you for joining us for tonight's educational webinar on hip impingement. Tonight's speaker is Dr. Brian Skura, OrthoNeuro's new sports medicine surgeon. Dr. Skura is a fellowship-trained orthopedic sports medicine surgeon specializing in minimally invasive arthroscopic surgery of the shoulder, knee, and hip, as well as total and reverse shoulder replacements. He performed a wide range of advanced procedures, including rotator cuff repair, shoulder instability surgery, hip labral repair, ACL reconstruction, meniscus repair and meniscectomy, and cartilage restoration procedures. Dr. Skura also offers expert non-surgical care for common conditions such as patellar tendonitis, Achilles tendonitis, frozen shoulder, joint sprains, and fractures. Please type questions in the Q&A box below, and Dr. Skura will answer the questions following his presentation. Dr. Skura?
Thank you for that kind introduction. Like she said, my name is Brian Skura. I'm a fellowship-trained sports medicine orthopedic surgeon, and tonight we're going to talk about hip impingement, what it is, and how to treat it. So, have you ever had hip pain where it's kind of grinding or pinching in the front of your hip, and you were leaning over and had this hand in your groin, or ever felt pain kind of going into the back of your buttocks? Well, we're going to talk about maybe some of the causes of that. So as you can see from this picture, there's a plethora of things that can go on in the hip. But we're going to be talking primarily about 1 through 3, labral tears, cartilage lesions, cam lesions, and what we do about it. So this is going to be the outline of my presentation. So we're going to talk about hip impingement, what it is, the anatomy, typical presentation of how it usually comes into the office. And then we're going to do a little bit of a deep dive into labral tears, cam lesions, pincer lesions. And if you have never heard of those, well, that's why we're here to learn about them. Then we're going to go into the workup and then some treatment options, whether that's non-operative or operative. But first, I thought you'd like to know a little bit about me. So I'm actually from Columbus. I went to Worthington-Kilbourne, where I met my then girlfriend and now wife, high school sweethearts. I went to University of Dayton, go Flyers. And then I went up to Erie, Pennsylvania, where I did medical school at Lake Erie College of Osteopathic Medicine. My wife stuck with me. We did a long distance relationship for 4 years, so she's certainly a trooper. Then I came back to Columbus and I did my residency at the Ohio Health Doctors Hospital, where I rotated through all the major hospitals around Ohio Health, including multiple different private practices. So I got a breadth of experience there, and where I also met some really great guys. These are my co-chiefs, co-residents, and 2 of them actually also joined OrthoNeuro. So on the far left and right is Dr. Pashis and Gubeau. Dr. Pashis is a spine surgeon. Dr. Gubeau is a joint surgeon, both great guys. Then I did my sports medicine fellowship down at Beacon Orthopedics and Sports Medicine in Cincinnati. There I helped take care of the Cincinnati Reds as well as multiple other smaller high schools, a couple of the local colleges such as Wittenberg and Miami University. So I got really great training down there. It was an awesome experience. And now I'm here. And outside of medicine, I like to root for the Buckeyes. So this is me and my wife at the Ohio State-Michigan game last year, where we froze our butts off just to watch the Buckeyes lose, but still go Bucks. And then we're also teaching our son to be an avid Buckeyes fan. And outside of that, I like to do outdoor activities like skiing, golfing. And this is me cooking a little bit of smoked meats in my garage. So I'm passionate, have a lot of passions outside of medicine as well. So let's dive into hip impingement, aka femoral acetabular impingement, or FAI. So this is just a short animation showing just an example of what I'm talking about. So this is a cam lesion, and this is in your hip. So this is on the ball side of your hip socket. And what happens is when you go into deep flexion, or when you're doing like a squat, that bone can rub against the cartilage and labrum. And that's going to be depicted here in the red as an injury to the area. So this is just one example of what we're going to be talking about with hip impingement. So let's do just a short, brief anatomy session so we kind of have an understanding of what we're going to be talking about. So the femoral head is the ball of the socket. Acetabulum is the socket side. And then we're going to be talking about the cartilage, depicted here in blue, and then the labrum. The labrum is a cartilaginous piece of tissue around the socket that actually helps hold the ball into the socket. So what exactly is this femoral acetabular impingement? Well, it's a dynamic condition. And what do I mean by that? Basically, it's when the femoral head, the ball, hits into the acetabular rim or the socket, and essentially smashes that labrum and cartilage in between the two bones. So that can lead to labral tears. That's caused by repetitive hitting of the ball and socket, leading to the tears of the labrum and possibly the cartilage. We can also see cam lesions, and that was seen in that first animation. Essentially, that's when you have an aspherical femoral head moving inside that acetabulum. And then we can have pincer lesions, and those are when you have too much bone on the acetabular rim. And you can also have combined lesions where you actually have both. Now, most people live a long, active lifestyle with FAI without even knowing it. But once pain actually occurs, that is when there's likely damage to that cartilage or labrum. So the labrum, let's look at a list a little bit more. So what are they? Why is it? Why does it happen? So the labrum is a piece of fibrocartilage that wraps around the socket to help hold the ball in place by a suction seal effect. That helps hold that ball into the semi-shallow acetabulum. Nerves supply that labrum in the front, top, and back of the labrum. So when we get tears in that labrum, they can be very painful. Why do we get these besides FAI? Well, it could be a trauma such as a fall, sports injury, or car accidents. We also could talk about micro instability. So that's basically when there's small, subtle motions in the hip joint over time. That could be from muscle weakness or other conditions. And then also degenerative tissue, degenerative changes associated with arthritis. Now, when that labrum is damaged, the suction seal can be compromised, and this loss can lead to increased joint instability, a pain or catching sensation during movement, and accelerated cartilage wear, potentially contributing to conditions like osteoarthritis. So if you looked in the bottom right, this is an example of a labral tear within the hip joint secondary to the FAI. So a cam lesion, so we stole this from basically the engines, like a camshaft. So it's caused by an aspherical femoral head moving inside the acetabulum. These are just a couple pictures, animations showing where that extra bone goes onto that femoral head and what it looks like, almost more of an egg shape than a sphere. It's typically seen in athletic men with a near male predominance of 3-to-1. Why do they happen? Well, it typically occurs during the childhood development years. It can be secondary to a trauma. So if you injured your hip when you were younger or broke your hip bone, genetics do have a play in this as well. And it could be the result of other diseases. And how does it cause the damage? Well, if you think of that aspherical head being more of an egg shape, moving inside the spherical or round acetabulum, every time you're flexing your hip or rotating your hip, you're essentially banging into that labrum and cartilage. And typically we see injury to actually the cartilage first, and over time the labrum will fall and tear. Now let's talk about the other side of the hip joint, the socket. So again, we aren't very creative and stole this from this pincer type tool here. And so what is it? It's caused by too much bone covering the socket, and this extra bone on the rim of the acetabulum hits the femoral head neck junction during hip flexion. So if you can imagine in this cartoon here, every time you move your hip motion, it's going to bang into one another, and that labrum is going to be caught in between, essentially pinching it and causing it to possibly fail and tear. This typically occurs more commonly in middle-aged women when they do get symptomatic. What causes these? Again, there's multiple possible causes. It could be just too much bony overgrowth. There could be a loose bony fragment from a possible old injury, or the overall socket shape, just how you developed. What happens is similar to a cam lesion, like I said. It's when that labrum cartilage gets crushed in between the acetabular rim and the femoral head neck junction. So how how do we usually see these, or what do you usually feel when you have maybe a FAI or labral tear? Well, usually, honestly, it starts without a specific injury and has been going on for possibly a while. But it can be after a twisting or pivoting injury, and you just start noticing it now. It's oftentimes a presentation of a vague hip pain. So as you can see from this cartoon, there's a lot of areas where hip pain can be many different things. So getting to the bottom of it can sometimes be a bit tricky. What we're going to focus on is this letter A. Oftentimes, or most often, the actual hip pain is deep in your groin. Other areas, other things that can mimic this are such things as hip flexor tendonitis, IT band syndrome, trochanteric bursitis, and other muscle strains. And oftentimes you'll often tell people, yeah, I have this hip pain, and make this C sign. I almost grab your hip with like the letter C. It's worse with sitting for prolonged periods of time, and you get relief with standing and straightening your hip and leg. Pain with activities such as running, squats, or climbing stairs when your hip is going into that deep flexion motion, and often experience a decreased range of motion of the hip. You could imagine if there's too much bone around the hip joint, you won't have as much internal and external rotation around the hip joint. So when you come into the office, what will your visit typically look like? Well, we'll get x-rays. We'll go through a brief history. We'll do a really thorough physical exam to really hone in on what exactly is going on. And then we'll have a discussion. Do we need to get further imaging? And then what does treatment look like? Is this something we could treat non-operatively, or is this something maybe we have to have a discussion about surgery? So these are your standard x-rays you get in pretty much every office visit. So the first one is what we call an AP pelvis. It helps us look at both hip joints and to make sure that they're symmetric and that there's nothing going on in one hip that maybe the other hip doesn't have. Then we often get a zoomed in x-ray. This middle picture here, this is called just an AP hip. And that just helps us zoom in really on and focus in on what is exactly going on in that one specific hip that's having pain. This is a lateral hip x-ray. So this is looking at the side of your hip. And this just helps us get a better idea of exactly what's going on and helps build a 3D picture in our brain. Rather than just having one view, we need multiple views to really see what's going on. And oftentimes when folks come in for hip pain to see me, I like to get some special views. I'll definitely always get this done view. So they'll often lay you down on the table or have you standing up and put your hip into this certain position. So if you can notice here on this hip here, there's this extra piece of bone. And we are pretty much only seeing that because we're rotating your hip and putting it in perfect position to be able to see that. This false profile view helps us better look at the socket and see if there's any bony overgrowth or other changes that we may not have seen on the other x-rays. In terms of physical exams, so we often will evaluate how you're walking. Do you have a painful gait or an antalgic gait? So are you limping when you're walking? Do you have a Trendelenburg gait? So is your hip dropping to one side or the other because of weakness in one of the muscles? We'll check the range of motion of your hip. Most oftentimes your flexion, so when you kind of do that squatting position and we turn your hip inwards, that'll be diminished. And you actually may have more outward rotation than inward rotation. We'll palpate bony landmarks and muscle origins and insertions to make sure you're not having other tendonitis rather than deep hip joint pain. Also take you through a battery of special tests just to make sure we exactly know what's going on. So those special tests kind of look like this. So the Stinchfield test will essentially have you raise your leg straight off the table and resist it. If there's pain reproduced down into your hip joint, that typically hones us in that there is something actually going on in the hip joint itself. Our most sensitive test is the impingement test. So we'll flex your hip and then we'll bring it in towards the middle of your body and turn it inwards. And then we'll do another test called the Patrick test, where we essentially do the exact opposite of that, where we take the hip out and bring it into outward rotation. And there's also another test where we looked at the posterior impingement to see if there's impingement actually going on in the back of the part of the hip. So once we do your physical examination, and we got your history of what's exactly going on, and we suspect that, you may have a labral tear or you have possibly femoral acial impingement based on x-rays and history taking and physical exam findings. So if we do get advanced imaging, oftentimes we will need to get an MRI. And that sometimes does include dye in the hip if we're really suspicious of a labral tear. So as you can see on these couple of views of the MRI slides here, the black triangle is your labrum. And this is just in a 2D view, but it shows that there's some fluid going up into the labrum, indicating a tear in that labrum. It just gives us a really good view of the overall ball and socket and the soft tissues around the hip joint. Now, sometimes we do get a CT scan if we do see a large cam lesion. The CT scan will be put into 3D format, and that really helps us map out exactly where your bony impingement is. And as we'll go over in surgical planning and surgical treatment options, This is something that's maybe shaved down, and we really want to hone in and make sure that we're shaving down the correct areas to free up that impingement area. Now let's talk about treatment. Oftentimes we will start with non-operative treatment. So hip injuries can often be initially managed with physical therapy, activity modification, anti-inflammatories such as ibuprofen, Advil, Tylenol, etc. So the goal of physical therapy, really working on core strengthening, gluteal strengthening, as well as the overall lower extremity musculature strengthening, as well as making sure you're maintaining good posture and working on hip mobility. Activity modifications. So we would ask that you kind of starting to avoid activities that cause impact and deep hip flexion, like HIIT classes, CrossFit classes, or if you're like a football athlete, we may hold you out for a period of time to help cool down your hip. We may offer a steroid injection. So that's helpful for diagnostic and therapeutic purposes. So if we do an injection into your hip joint itself and you do get relief, more likely to have an injury actually in the joint. So we're not only bringing you pain relief, but it's also really telling us you do have pathology down in your hip joint rather than having something going on outside the hip joint itself. Now, if you don't get any relief, then we may have to start seeking out sources of pain outside of the joint, such as those muscular injuries, or maybe even it's coming from your lower back. So this steroid injection often does help us really determine if that pain is coming from your hip joint itself. Now, if we get into the discussion of talking about operative treatment, what are the goals of that? Well, we're going to address the causes of pain, which are typically that cam and or pincer lesion, labral tears, as well as the cartilage damage. And the goal of that is to prevent premature development of arthritis. So indications, so failure of non-operative treatment. So when you have continued pain, even after doing physical therapy, steroid injections, activity modification, on X-ray, an advanced imaging diagnosis of FAI and or labrum and cartilage injury, you have positive exam findings consistent with impingement, and there's no evidence of advanced arthritis. And what I mean with that is on your X-ray that there's still good joint space maintained, no changes to the bone. And the only reason I say that is because if you do have evidence of advanced arthritis in the hip, a hip scope may not be the right choice to do for you, and that we may have to have a discussion about a total hip replacement. But we're not going to discuss that at this juncture. We're just going to keep focusing on hip arthroscopy. So what is hip arthroscopy? It is somewhat a niche field. Not many people are doing it, but it's a minimally invasive outpatient procedure performed typically at the surgery center. It involves making 2 to 4 small 1 centimeter incisions around the hip joint. We use a fiber optic arthroscope to look around the joint, really diagnose what's going on in there. We can see a lot of things on MRI and CT scans and X-rays, but really seeing it with our own eyes using a fiber optic scope is the best way to treat and or to diagnose and treat that issue. We introduce tools to clean up any damaged tissues, and then we'll use anchors and suture to repair the labrum. And then we use a burr to remove any excess bone from the acetabulum or pincer lesion and or femoral neck, the cam lesion. So what does a hip arthroscopy look like? This is just a simple animation showing what hip arthroscopy looks like. So as you can see, make a few small poke holes, introduce a couple of tools and a camera, and we go in there, burr down the cam lesion. So now you'll have impingement-free range of motion. And we would also address the labral tear if there is one. And what we do is we put anchors into the bone and we suture it down. And then it allows it to heal and repair that suction seal effect. So labral repairs, why and how we do it? Well, we can restore the suction seal by repairing or reattaching the labrums to its proper position, addresses any underlying issues such as bony abnormalities that may contribute to labral damage, and a restoration of that suction seal. So that's the important goal of hip arthroscopy, as it is essential for joint stability, health, mobility, and long-term function. So after surgery, so when you wake up, what does that look like? You'll be given pain medicine, anti-nausea medicine, anti-constipation medicine, anti-inflammatories, and typically aspirin to prevent blood clots for a couple of weeks. Bracing and weight bearing. you'll be placed into a hip brace that will be applied that limits motion in certain directions for upwards of 2 weeks. You will have crutches after surgery, and then you'll be limited in your weight bearing, where you're really only putting your foot on the ground, not so much to put weight bear through, but really just to balance. And then you'll progress up to a full weight bearing status over the course of the next 4 to 6 weeks. And then returning to sporting activities, physical therapy will generally start week one, just working on gentle hip range and motion. Just keep the hip nice and loose. As you kind of move forward through physical therapy over the course of 3 to 4 months, we'll get you back into a return to sport protocols and make sure you're ready to, hit the pavement, get back in the gym, whatever you're going to do. And these are just a couple of athletes, Alex Rodriguez, Tyson Gay, that have had hip arthroscopic procedures, and obviously they did very well in their careers. Thank you. I hope you enjoyed the presentation. Now I'll gladly answer any questions.
Thank you, Dr. Skura. So we have a few questions here. First question is, what are the long-term outcomes of an untreated hip impingement?
So some studies have shown that undiagnosed and untreated hip impingement, if there is evidence of cartilage damage, that will continue on. So you could imagine that hip impingement, the cartilage continuing over and over to get damaged. In osteoarthritis, what is it? It's essentially cartilage breaking down. And as that progression starts, it really doesn't stop, unfortunately. So as it kind of continues to go along, there can be more rapid osteoarthritis than in a person that doesn't have it. If a person gets it treated versus untreated, the person that's untreated may have more advanced arthritis at an earlier age.
How do you differentiate hip impingement from other causes of hip pain like bursitis or labral tears?
Yeah, so that's kind of going into really diving into the physical examination. So we often start with palpating around the hip. So having pain in certain areas is really indicative of outside sources of hip pain other than the hip impingement. So like hip bursitis is very, very painful over the side of the hip near the greater trochanter. It's exquisitely tender to touch, and it's even hard to really even sleep on. So that's what some of the most red flags are when people come in. They say, I cannot sleep on my side. It's super painful. Other things that really clue into the hip joint is folks pointing straight into their groin, as well as doing those special tests where we bring your hip into flexion and turn it inwards and outwards. If there's pain that's reproduced down into the hip joint itself, that often indicates that there's pain originating from the hip joint rather than outside the hip joint.
Sorry, I was muted. Are there specific lifestyle changes that can help prevent or manage hip impingement in the long term?
So folks that are more active typically they don't degenerate faster, but they often will see this at a younger age than folks that maybe have a less impactful lifestyle, just because they're using their hip more. But that does not mean people should be not active. I think strengthening around the gluteal region, the hip abductors, the lower musculatures, your core is essential. It helps stabilize the hip joint. Anything that helps stabilize the hip joint, such as strengthening those muscles, is really important. And just unfortunately, if you have a cam lesion or a pincer lesion, those are bony changes. And unfortunately, those are really hard to get rid of. You can't get rid of them because they're part of your bone. And so what you can do is activity modification. So, avoiding those activities that really get you into those dangerous situations like deep flexion. So maybe if you're really into squats, don't go past 100 degrees. You don't need to go and put your knees all the way to 120 degrees. You don't have to go super low. You can stay nice and high. You don't have to do those deep lunges. You don't have to do all these exercises where you're having high impact things like box jumps or running for prolonged periods of time. Unfortunately, I know a lot of people really enjoy those things, but sometimes you have to do a little activity modification, and doing walking on the treadmill will just have to be your new thing rather than running the ultra marathons.
Is there a connection between hip impingement and certain body types or postures?
Not necessarily. So hip impingement, like I kind of alluded to, is something that happens during childhood. And so what we kind of see is cam lesions are typically found more in men, and then pinch lesions for whatever reason is found more in women. Unsure of why that exactly is. Body type morphology, it doesn't, I mean, there may be a genetic predisposition to that, but it doesn't really preclude you to have hip impingement necessarily. If you had maybe an injury when you were a child, that may lead to hip impingement at some point if your bone healed in a certain way, but it doesn't necessarily mean that's a guarantee. But I wouldn't say that, having a certain body type or morphology or anything like that, nothing that a patient did would really, preclude you to having impingement necessarily.
38-year-old male, have had two labrum tears in my right hip fixed with surgery and now have a labrum tear in my left hip with surgery scheduled in October. Any advice?
Sounds like you know, unfortunately you're a professional with the right side, and you know exactly what's going to be coming from it. Um, yeah, that's often what we also find, is that if you have it on one side, there is a predisposition for whatever reason to have it on the other side. And so advice, follow your physical therapy, really hone in on the muscular strengthening, following the guidelines for weight bearing. But otherwise, hip arthroscopy, I think, is a really great option. Um, I know you had two. I don't know why maybe you had two on the one side, but I would just say stick to physical therapy, follow your physical therapy guidelines, weight bearing guidelines, and you should have a really good outcome.
How would you treat a bone spur?
So bone spurs don't necessarily mean it's a hip impingement problem. So bone spurs are often associated with osteoarthritis. And like I was saying, once we start getting those osteoarthritis changes on X-ray, we typically don't do anything with bone spurs necessarily. So if you're, younger and you've developed this bone spur for whatever reason, if you had maybe an old injury and now it's turned into this small bone spur and it is causing impingement, it is something that, theoretically could be treated with a hip arthroscopy by shaving it down if it is causing impingement. Um, but if it's more associated with arthritis, then it's something that would probably be managed first with non-operative treatments such as anti-inflammatories, activity modification, PT, injections. And then if you develop arthritis over time, then it may be a discussion of a total hip replacement, that is.
What happens after surgery if you cannot use crutches?
So if you can't use crutches, there's other walking devices that we can get, such as walkers. There's different types of crutches that we could use. It certainly depend on, I guess, the reason of why you couldn't use a crutch. We'd have to definitely find a way for you to start mobilizing, because one goal is I never really want folks to not be completely non-weight bearing on that lower extremity. I think it's important to keep that hip moving, even if it is a limited motion at first. So certainly finding ways to avoid the wheelchair, but if a wheelchair has to be used for, transfers or getting around for the first couple of weeks, then that's something we can work around. Um, but I think if we can kind of really hone in on why crutches couldn't be used, whether it's a comfort thing, physical therapists are really great at crutch gait training. So that's one area that we could really focus on even before surgery. So we can send you to prehab and have you work on more, using crutches and getting comfortable. And if not, then there's certainly other options.
Are there legitimate, effective regenerative therapies or medicines available to heal the labrum and cartilage?
So I know orthobiologics is a very hot topic right now. A lot of people hear things like PRP or platelet-rich plasma, stem cells, bone marrow aspirations, amnion, all sorts of things that could be injected into joints to restore that cartilage. Unfortunately, that's not completely true. PRP is certainly a good option. If you have a labral tear and you don't necessarily have this cam morphology or pincer, so you don't have a bony problem, but you have this maybe from a traumatic injury and it's a small labral tear. PRP is theoretically a good option. I think we're still figuring out exactly what to do. The literature, there's nothing that's 100% saying we should do this, but I would be wary of anyone that says we can regenerate cartilage and completely heal tissues using those modalities, because we're just not there yet, but it's certainly something we could trial non-operatively to see if we could get your pain down and theoretically heal that labral tissue, at least scar it in back to a good place where you're not having pain and pinching and catching sensations. But unfortunately, once you have cartilage injury, there's nothing short of, replacing that cartilage with certain procedures that the hip, we haven't quite got there quite yet. In the knee, we are doing that a bit. And we could do things that replace different types of cartilage in the hip, but nothing where we're regenerating it like new. Yeah.
Can one have sciatica and hip impingement?
Absolutely. Yeah, just because you have one doesn't mean you can't have the other. Sciatica, certainly a very common problem. And sometimes, like I was saying, hip impingement and hip pain can be sometimes difficult to diagnose, which is called, what's one, what's with the other. And so getting to the bottom of it can sometimes be tricky, but you can certainly have both going on at once, and getting to the bottom of that is certainly something that we have to dive deep in on a physical exam, different possibly injections or nerve studies or imaging studies. So yeah, there's definitely a lot of different things we could do to get to the bottom of it.
What age is too young for hip replacement?
So that's a question. Um, and I'm sure I would like to defer to my joint replacement surgeons. I would say, if you're in your 30s, that is certainly too young. But it's not, people have had their hip replacements done much earlier than that. I think if you can get into your 50s, that's the ideal time. Hip replacements do phenomenally. People do really well with them. If there's any orthopedic surgery that we do, I would say hip replacements is one of the, ones that people really, really do well with. And so I just think if you can kind of prolong it into your mid to late 40s, into your 50s, ideally 60s, I think that's the best thing to do. However, there's a caveat. If your pain in your hip is so bad, you've tried everything, and now you're having pain in other joints, your lower back, you're walking differently, then that's something that, you may have to have a serious discussion on. There's, obviously things that you'll be limited in, and you'll have to talk to your joint surgeon about that. But, you know, the sooner you have it or the younger you have it, just the higher chance that you may have to have a second surgery later in life to possibly replace something. Um, but yeah.
I experienced what felt like a tear around my hip that was painful and showed visible bruising. It has since healed for the most part, but the hip area has never felt the same, but rather weak.
Okay. So I'd be kind of curious to know exactly where that tearing and bruising sensation was. When we hear those words, tearing and you get bruising, that obviously hones in on some sort of musculature. And so there's different muscles around the hip that can tear, not necessarily associated with hip impingement, but obviously there's a multitude of different muscles around the hip. Some are, heal in and scar in and they work just fine. Others, they tear and you can have continued pain over time, especially the ones on the outside part of your hip. Um, and those sometimes may need a little bit further workup than other muscles for sure.
If I'm already an established patient at OrthoNeuro with Dr. Palmer for a knee issue, should I see him for this as well or schedule with you? And another question, do I need to get imaging before coming? My symptoms are several of what you've described, especially hard to sleep on that and bend.
So Dr. Palmer also does hip arthroscopy and he does a great job. I've been on surgery with him. He is awesome. So you can certainly just follow up with Dr. Palmer and he'll really treat you well and he'll do an amazing job. So in terms of having imaging beforehand, not necessarily. This is something where we can have a discussion, obviously, in the office about, is this something that we do have to get an MRI for because we're concerned about a hip labral repair, or hip labral tear? Or is this something maybe we can trial a period of non-operative treatment and see how you do? So I think it's something where you go in and have a discussion with your surgeon and then kind of take the appropriate steps from there.
I already had a dual total hip replacement, still having problems with pain in the hip area. Is there any additional treatment?
So that's a difficult question to answer. There's a few things that could be definitely going on. Biggest thing I would just say is I would follow up with your hip surgeon and see, what they had to say about it because, they've followed you with x-rays, they've seen your course after surgery, so they'd have a really good idea about what's going on. So that's kind of my biggest thing is just following up with your surgeon and just seeing, what they have to say about it. And if they think there's further workup that's warranted, then they may pursue different things to try and figure out what exactly is going on.
So, so you should avoid HIIT.
Oh, hit training. You don't have to necessarily avoid hit training, but it's certainly a higher impact activity if you are having hip pain. And it's definitely something that, you're doing a lot of box jumps, burpees, things where you're putting a lot of impact on your hip. And if you're having hip pain, I would be wary of, fighting through that pain. It's the old adage of no pain, no gain. It's not necessarily true. So I just often promote if you are, wanting to do those hit type of workouts. I mean, they're cardiovascular workout. You're doing timed intervals. You're getting your heart rate up. You're doing an, awesome workout. It's just doing those higher impact things. So instead of doing a box jump, maybe do a step up. Instead of doing burpees, maybe just do a plank burpee instead of going all the way down and jumping back up. It's avoiding those high impact activities and reproducing that pain that I would just be wary of. But there's certain ways that you can certainly modify those types of workouts to still get a killer workout. And I'm all for fitness and working out. And so, yeah, any way you can kind of navigate around that if you're passionate about hit workouts is something that you want to do for a long time. I would just say modify some things and find ways to continue working out, but in a safe way to protect your joints.
I missed the first 10 minutes, so forgive me if you've already addressed this. I have pain in my hips and groin pain that feels deep, like it's muscular, and in the joint going up the stairs. It started after giving birth 22 years ago.
Yeah, and so that's kind of a classic, this is coming from the hip joint. It's deep in the hip, not necessarily from after giving birth, but having these deep flexion things like going up the stairs certainly sounds like it's coming from the hip joint itself. And so whether this is an impingement issue or other labral pathology sort of thing, certainly could be evaluated by myself or another hip specialist for sure.
Having a terrible time getting in and out of a vehicle.
Yeah, and if it's that kind of deep, that's a classic type of scenario is you're sitting down for a prolonged period of time. Often your hip is in this deep flex position. And then when you get out of the vehicle, it's super painful because you've been sitting there kind of putting a lot of pressure probably on that hip joint. And so when you get up and out of that vehicle, it's pretty painful. So yeah, that's another kind of classic story and symptomology for hip joint pain.
What is the recovery time after hip arthroscopy for FAI?
So if say you have a labral tear and a cam lesion, so the surgery would look like shaving down that cam lesion or that extra bone and repairing that labral tissue. So you'll be put into a brace after surgery. For the first couple of weeks, your weight bearing will be just kind of putting your foot on the ground and then gradually progressing up over the course of the next 4 to 6 weeks to full weight bearing. Once we get to that 4 to 6 week mark, we'll really start working on strengthening that lower extremity uh, with the goal of getting back to sport or whatever activity you want to get back to at that around the 3 to 4 month mark. But you'll be up and walking with crutches or other assistive devices right after surgery. It won't be something where you're not putting any weight on it and kind of laid up. It's all outpatient, minimally invasive. So relatively low pain, but it will take all of 3 to 4 months to really get you back to that full activity.
Are water exercises being less impactful, show delay in offset of pain from arthritis, and help build muscle as well as without water to buffer the impact for a
Yeah.
76-year-old male?
Yeah, water exercises are awesome because yeah, like you said, they're low impact. You're still getting a great workout, cardiovascular workout. You're working your muscles. I am all for water type aerobic exercises. Yeah, it's definitely a really great choice.
What about labrum fraying? What can you do about that?
So labral fraying, if there isn't a definitive tear and it's still causing pain, you've tried all these non-operative modalities. That certainly, if you had a discussion, if you opted to do a hip arthroscopy, the fraying, if whatever we look at in the joint, if it is just a frayed piece that's kind of flipping in and out, it can certainly be shaved down. And if there is found to be a tear, that small area where it was fraying may actually be a small tear, and that could be repaired.
What does it usually mean when you're walking and your hip gives out real quick and scares you? Then you walk very carefully when it goes back.
So hip giving out could be so it's oftentimes people describe it as their hip is dislocating and is not the hip actually dislocating, but it feels like it. And it's usually because there's weak muscles on the outside part of the hip. And so there's muscles on the outside part of the hip that help keep your pelvis and overall center of balance stable. And so if those muscles are weak on the outside and your pelvis is unstable, it feels like your hip gives out and then your whole pelvis gets off and then you feel very unbalanced. And so I feel like the culprit, just on this short story, is probably one of the muscles or some of the muscles on the outside part of the hips may be weak.
Do you know much about Ehlers-Danlos syndrome? I've had a hip replacement on March 31st and fell and dislocated 8 days post-surgery. I did everything possible before surgery. I'm an active 76-year-old. I had tears in my glute medius and minimus. I still can't walk without an aid. Are repairing glutes difficult with EDS?
I am familiar with EDS, and it doesn't necessarily make it more difficult. I know, with the connective tissue disorder, the goal is still to get that tendon to heal down to bone. And so it sometimes is difficult to do at baseline, but doesn't make it any more challenging or difficult. But certainly with having a hip replacement, I think talking with, the surgeon there about the overall construct, as well as if the glute med and glute minimus are torn, oftentimes repairing those can help with the stability of the hip.
That was our final question. Are there any additional questions? Thank you very much, Dr. Skura.
You're welcome. My pleasure.
Thank you for participating in tonight's webinar. Our next webinar will be held on October 14th. Dr. Braden Pashis, OrthoNeuro's new orthopedic spine surgeon, will speak on spinal stenosis. Enjoy the rest of your evening. Good night.
Good night.